Obesity 2.
I know I should have good unplug now. I'm gonna let it down for now. People can you pull up?
Yeah, I'll grab it.
Thank you. Not good. I'm not using a freaking mouse.
But you can always. I'm a little.
Yeah, and there's no Saturday and then Monday.
No, you should know. Kilograms, how you convert that, right? But
The meters I
don't know. Yes, and also equal to or greater than 40 and equal to or greater than 5. No. The greater than, I would call that still the gold standard.
Yeah.
You want to be less than
I was joking.
It takes a while, but
That's true.
it's like maybe like 5 8
Skin test has 3%. Right, but if the person looks at their weight, they call a market rare at 3%. It's not like that was 100%. It's not that. It costs so much less. It's free in some places.
Like half horse, half man. What roses?
Who's that horse, half man?
Talking about Italy, like half horse, half man. Strong accent. Strong accent. Never hand. Some pasta carbonara.
Perfect.
I'm really sorry.
Yeah, it seems it has to be right. Got covered.
Dream day. Let me know if it's too much. I'll see what I do. There's no box or something that says box. We already got all that. I don't have a mouse.
Everybody understands. So you have an increase in risk factors for heart disease and those complications we discussed if the male has a waist circumference equal to or greater than 40 and or the waist-hip ratio greater than 1. For the female, it's the waist measurement of equal to or greater than 35 and or the waist-hip ratio greater than 0.8. And the 0.8 and the greater than 1 are indicative of the apple-shaped obesity or upper body obesity or central obesity. It's that like spare tire around the belly, the beer belly, things like that. That's what you would think of and associate it with. Okay? Okay, so management. Of course, there's diet. They recommend some places you need to decrease your diet. You shouldn't go lower than 1,000 calories a day. It really depends on what diet you're following. There's so many diets out there. I've always had the thought process and known or been told by my physician that the ones that are with extremes, unless there's a specific reason you're doing it, like the keto diet and where you are very limited or very restricted, they work, but sometimes for some people they're really hard to stick to long term, and it has to be a way of life. So with certain diets, it's not that they don't work, and there are health benefits to all different types of diets and problems and complications with all different types of diets. It's hard to say are the complications worse than being obese, so you got to kind of weigh the good and the bad, but it's mostly you don't want to spend all this time trying to reduce your weight and be successful just to gain it back, because that hurts people more in the long run because they become more resistant to losing weight overall. So usually if they gain it back, they're at a higher risk for gaining back more as well. So it's, kind of whatever is chosen, whatever type of diet that someone is recommending or is following, it needs to be an overall lifestyle change. And I think that's the smartest choice as opposed to I'm just doing this diet. No, I'm changing the way I eat. Needs to be like a concept like that, because you have to think in that way. Exercise is very important. Certain types of exercise, we know that weightlifting helps increase your BMR. Exercise, however, is more important in keeping weight off than it is in losing weight. Diet is going to be the number one thing that helps someone actually take pounds off. It is very important for being healthy, however. Behavior modification, I don't know, it is just as important, because people have to change their lifestyle. They have to change why they eat. They have to not only change what they eat, they may have to change when they eat. So it's a whole lifestyle behavior modification. They need to figure out why they are doing the things they're doing and eating. When are they eating? And what are the emotions that go along with that? Because it may be some emotional, psychological factors of why they're eating and what they're eating. There's also pharmacological therapy, and there are surgeries, and we'll go over those. So, a lot of diets will say small, frequent meals. Spread it out over the day. You need to create a 500 to 1,000 calorie deficit in order to lose weight. Gradual, slow weight loss is recommended usually overall, even though we like those big drops. It's not as easy to keep those or sustain those. So 1 to 2 pounds is a good goal. Excessive calorie restriction, can lead to guilt. It can just be extremely difficult to, if you eat the wrong thing one time, you've blown it, and there may be guilt associated with that, and that may lead to, I've already messed up, I might as well eat the whole bag of Oreos. So, happens. Unless you're like my husband, and he does the Bobo Oreos and takes the Oreo pack and puts the Bobo Oreos in the Oreo pack. I know what I'm talking about. And then tries to play it off to my granddaughter like his Oreos. I'm like, she is going to grow up, and she will know those are not real Oreos. He buys the cheap Dollar Tree Oreos and puts them out. Yeah. Messing my baby up. So that's my husband. Anyway, so for women, 1,000 to 1,200 calories a day. They don't want to recommend going lower than that, and then men, 1,200 to 1,600 calories a day. If you go lower than 1,200, there's that risk of lean muscle tissue loss. Yes.
Are these the recommendations for if you want to lose weight, or if you want to, that's what they recommend daily?
No, for losing weight.
For losing weight.
Yes, losing weight. But you know, there are some diets or lifestyles that say that's too little, and you actually, it's what you eat, and you can eat more calories, but you have to eat certain food. There's so much out there. It's so confusing sometimes. It needs to be well balanced. Whatever someone chooses, whatever diet they choose to follow. And the big thing is, once we're talking obesity and morbid obesity, even more so, you know, you're already at a really high risk. You're dealing with someone who's at a really high risk for complications and health problems. So, yes, there are going to be some health problems and complications that may be associated with the treatment options, but the person has to balance that and figure out which one is, what are the pros and cons and which one to go with. So, aerobic exercise, most time they recommend 30 to 40 minutes either every day or 4 to 5 times a week. Of course, the more days per week, the better. When it does increase the BMR and it can preserve that lean muscle mass. Behavioral modification, we talked about that. The biggest thing is replacing it. Food diary works if you do it, and identifying triggers. Okay, different medications. What I really want you to know about the different medications that are associated with weight loss or used for weight loss is majority of them work on appetite suppression and that feeling of fullness. So it's going to decrease someone's appetite and or cause them to have a full feeling. There are a couple that don't work like that. One in particular, Orlistat, which is Xenical, right here. This one right here, Xenical or Ally. If anyone knows that drug, raise your hand. Not like you've taken it, but you just know what it is about. Or can, they tell you to take an extra pair of clothes with you because it blocks fat absorption. And so the fat's got to go somewhere, so it goes straight through you. And I'm told that there is like this black tarry stuff that will ooze from your body. So the symptoms with that, or the problems with that you're going to see, the side effects are going to be fatty stools, flatulence, fecal urgency, sometimes to the point where you can't get to the bathroom, don't wear white. They also, so it's kind of one of those things, is it Pavlov or whatever, that if somebody takes something, you hit them, they don't take it anymore because it's a negative, Well, anyway, you eat fat, it goes through you, that don't feel good, it don't look good, so you stop eating fatty things. So most of them are decrease your appetite and increase the fullness, but Orlistat is the different one, or one of the different ones. Okay, surgeries for morbid obesity. And I think you don't have to know specifically what these surgeries are. The biggest thing is knowing which ones cause which problems. And also, what are you going to do for your patient who's had these surgeries or has these problems? So if you know your patient has had a restrictive malabsorptive surgery, you're going to have to expect they're not able to absorb nutrients, okay? So they may have some vitamin deficiencies. So these are people, they offer surgery to people that have tried diet, they've tried medications, they've done everything right, and they just cannot lose the weight. And or they have severe obesity-related complications already. So they have high blood pressure, they have heart disease, they have all these things. They really need to get the weight off. Two of the restrictive malabsorptive are the gastric bypass, also known as the Roux-en-Y, and the biliopancreatic with duodenal switch. So those two, what they're doing is they're creating a smaller stomach, and they're also rerouting things so they bypass where most of the food is absorbed. And those are permanent changes that occur. These cause rapid weight loss, and it is very well maintained, usually 60 to 70% of the weight, people who lose the weight, is maintained for 10 years or more. They are at a really high risk for nutrient deficiencies, especially iron, calcium, B12, and any of the fat-soluble vitamins. We also have the restrictive, which are adjustable gastric band and the vertical sleeve gastrectomy. In the sleeve gastrectomy, they actually take off part of the stomach, so it's just restrictive. They're not rerouting anything. There's nothing to do with absorption. It's just a smaller area, so they're going to feel fuller faster. With the sleeve, with the band, it's actually, a lot of people refer to it as a lap band. They put the band around the gas. What did they actually put it? Right at the top of the stomach. And they put the band there, and what they can do is, it's a band that is hollow, and as they'll fill it with saline, and there's a little port that is placed usually somewhere around the umbilical area, and they can go in and with a needle fill that with saline, and it actually blows up that balloon around there, that band around there, and makes it tighter. So it will cut off how much food can actually go down. They physically cannot eat more than a certain amount because they'll throw it back up. It just won't go in. I had a very good friend of mine that had that done. Problem is, she had her lap band recalled, and she didn't go in and get it taken out, and it ended up eroding her esophagus. Eroding the esophagus. So it slipped and it eroded, and she ended up, it was leaking gastric fluid and stomach contents, and she ended up septic. It was really bad, but she's okay now. She was in the ICU for a couple weeks, but she's okay. And she ended up going in and having one of the bypass surgeries after she recovered.
You said all are permanent? All those options are
No, the band is not permanent. The sleeve, if they remove that part of the stomach, it's permanent. There are a couple other options that are available. There are the inflatable balloons, where they place balloons in the stomach and blow them up, and then they can, it controls how, it makes you feel fuller, so it controls how much food can actually be in the stomach. And then there are like a pacemaker, little neurotransmitter that's placed, and it actually blocks the nerve signals, nerve activity from between the brain and the stomach. So the person actually does not get the signal that they're hungry. There is also something that's, I don't know how new it is, but it is the gastric emptying system, which they place a tube. I would think of it as like a reverse G-tube or something. So instead of a tube that you can put food through, it's a tube you drain food out of. So So they place that, and they actually, after someone eats, they drain what they ate out of their stomach. Of course, the more complicated the surgery, the more, the ones that are permanent, not reversible, are going to give better results, and they're going to give results that last longer. The band is like 30, people will lose 35% of their weight, that's the average, and they'll keep it off like 3 years, is the average. But they say even a 10% weight loss can make huge changes in someone's health status and complications. So we have the nurse that is caring for a 54-year-old female patient on the first post-operative day after a Roux-en-Y gastric bypass surgery. Which assessment finding would be reported immediately to the surgeon? Now let's think about this. The patient has bilateral crackles that are audible at both lung bases. Would we expect that after surgery? Yeah, it might not be a complication. It's something we need to do some nursing care about. But think about it, they've been under anesthesia, so they've not been breathing deeply on their own. They've been on machine during surgery that's been breathing deeply. They had abdominal surgery, so they're not going to want to take deep breaths. So if we get them breathing deep, we may be able to open their lungs back up and get rid of that, those crackles, okay? We also, there's redness, irritation, and skin breakdown in the skin folds of the patient. Is that something we need to call the surgeon for right away? No? Yes? No, because that's normal with obese people to have some skin breakdown. We would want to put something on it, and we would want to talk to the doctor when we see them or when we're calling them, but it would not be something we needed to report immediately. Emesis of bile-colored fluid past the nasogastric tube.